Hi, my name is Maryam Kirnos, and I'm going to be presenting the case for Robert Taylor. He's a 56-year-old African American male who presented to our clinic with an acute case of depression. The HPI is Mr. Taylor, 56-year-old African American male with an acute major depressive disorder. Mr. Taylor has a history of hyperlipidemia, myocardial infarction involving the left main coronary artery, COPD, and depression. Mr. Taylor currently not on any treatment for his hyperlipidemia, his coronary artery disease, and COPD. The only thing he's currently on is the citalopram for depression. Mr. Taylor's total score on CAT questionnaire is 21, and his HAMD total score of 16. At present time, we have no information on Mr. Taylor's vaccination status, such as pneumonia, seasonal flu, or COVID. Mr. Taylor's past medical history consists of hyperlipidemia, coronary artery disease, COPD, and depression. We do not have much information about his family history and his social history. Again, we don't have much information about his tobacco use and alcohol consumption. He is allergic to adhesive, and his lab work, we do have that his red blood cell count is 4.2 cells per MCL, which is low. His BUN is 3 milligram per deciliter. His total serum protein is 8.4 gram per deciliter, which is high, and his liver enzymes are also high. His ALT is 42 and AST is 47. The only medication he's currently on is, again, citalopram. Our priority problem list for Mr. Taylor is at the major depressive disorder and COPD. His problem assessment of the problem we have is, excuse me, is that his depression is not controlled, and based on the HAMD total score of 16 questionnaire, he suffers from moderate depression. He has anxiety, he has a loss of libido, loss of interest and pleasure, he cries a lot. Again, he has loss of productivity at work. The assessment of a COPD is uncontrolled because of the score of 21 on a CAT questionnaire. He does has coughing, he has sputum production, and he does says that he's breathless when he walks up the hill or stairs. He has a limited activity at work and no energy. And according to that, those are the landmark for on COPD gold guideline. The assessment of his current therapy is for his COPD, there isn't any as of right now, and for the depression, the only thing he's on is on citalopram 40 milligram. The goal of the therapy for his major depressive disorder, if we want to achieve remission of his symptoms, we want him to regain his ability to participate daily in activity, in social interaction, prevent relapse, lifestyle modification, which could be also done through the CBT therapy. We want him to increase his daily activity and learn how to manage stress management. The goal of the therapy for his COPD is to control his symptoms of shortness of a breath, reduce the frequency and exacerbation of the COPD, slow down the progression and all the complications of the COPD. my recommendation for the therapy is to discontinue citalopram and start the patient on duloxetine. I will start him on maybe 30 milligram twice a day and increase it maybe to 30 milligram twice a day, or 60 milligram once a day, with a maximum dose of 120 milligram per day. And again, my rationale for duloxetine is that it is indicated for an acute and maintenance treatment of MDD, and also it's been used for a generalized anxiety disorder in adults and pediatrics. And in 4 randomized controlled blind studies that showed that Cymbalta 40 to 60 milligram twice a day has a lot more improvement in patients versus in placebo in improvement in the Hamilton Depressive Rating Scale of 17. A common side effect for Cymbalta is nausea, vomiting, diarrhea, constipation. Another advantage of duloxetine, and it does not have as much cardiovascular side effects as citalopram, and it has a huge impact on the QT interval prolongation. However, we do have to monitor the patient's blood pressure. We have to monitor the renal and liver function. We have to get a baseline on those at the beginning and at the first 2 months of the treatment. We want the safety and efficacy is measured through the improvement of the signs and symptoms of his depression and anxiety. My second recommendation is for his COPD. I want to start the patient on albuterol middle dose inhaler, which is a short-acting beta-2 agonist. That's to help to keep his exacerbation and his COB, shortness of a breath, under control. It is covered by most medications, and it helps to prevent bronchospasms. Has a rapid onset of action, and again, according to the COPD Gold Guideline, all patients with COPD is recommended to have a short-acting beta-2 agonist on hand. My third recommendation would be to start the patient on an inhaler such as Anero Elipate. It's dosed just one inhalation once a day. It's a combination medication of long-acting muscarinic agonist plus the long-acting beta agonist, and they seem to have a significant reduction in rate of COPD exacerbation. It has improved lung function. It reduced the risk of pneumonia when it's compared to just LABA plus inhaled corticosteroids per COPD Gold Guideline. Basically, Aneros, the way it works, it causes the bronchial smooth muscle relaxation, and they both are long-acting, so that helps with that. Another advantage of Anero is that it is excreted through the kidneys and feces. I believe that would be a better option for Mr. Taylor, since he has a high level of the liver enzyme, and that usually no dosage adjustment needed even for patients who have kidney or liver issues. So to me, that was a better option to go with. Another option that I think that Anero is a good pick is because since it is dosed once a day, it helps with the adherence. However, we have to monitor the patient, make sure that his improvement and maintenance of his respiratory function as well. We want to reevaluate him, reevaluate his cardiac function, make sure those are appropriate. We want to make sure that he doesn't suffer from any sinusitis or pharyngitis or chest pain. Those are the symptoms that he must have to report to his primary physician. We want to also make sure that Mr. Taylor is aware that to keep the medication at room temperature, discard any inhalers at 6 weeks after initial opening of the tray, or all of the blisters that are used, whichever comes first. I would want to have a follow-up with Mr. Taylor within 30 days of the start of the treatment. We want to reevaluate the patient, make sure that the sign and symptoms of his depression and his COPD is under control. Talk about any side effects that he might be having, whether it's for the duloxetine or from the albuterol or anero inhalers. We want to go over the proper inhalation technique with him on his anero and albuterol. We want to make sure that he reduces or avoid any causative agents that might exacerbate his COPD or asthma. Make sure that he also has an increase in his activity, his nutrition. Again, talk about his vaccination to get his his seasonal flu shots, pneumonia, and also his COVID. We want to maybe retake the CAT questionnaire with him and document and find out what's his status on his COPD and asthma. And again, the anero is covered by most major insurances. It costs anywhere between $35 to $44 per month, and it is covered by most Medicare Part D insurance. Thank you very much for your time. This is the end of my presentation.